and welcome to the ACR Journals on Air podcast. I am your host, Vicky Shamagam. Remember the mind twister you used to talk about when you were a teenager? If a tree falls down in a forest and no one is there to hear it, does it make any noise? That sprung to my mind when I was reading the manuscript we're going to be discussing today, Genicular Nerve Block for Pain Management in Patients with Knee Osteoarthritis, a randomized placebo-controlled trial published in Arthritis and Rheumatology. There is a link to the manuscript in our show notes for this episode. And I'm pleased to be joined by the first author of this manuscript, Professor Michael Shanahan, Professor of Musculoskeletal Rheumatology Medicine at Flinders University College of Medicine and Public Health in Adelaide, Australia. Welcome to the show, Michael.
Thank you, Vicky, and thank you very much for inviting me to come along and speak with you.
So normally in our podcast, we like to spend a bit of time at the end of the show getting to know our guests. But today, in honor of Australia, I'm going to turn things upside down and start with some rapid fire questions, if that's okay.
I'm ready for it. Yep.
Okay. So just to orient people to the time difference, it's evening here on the East Coast of America and breakfast time for you in Adelaide. So my starter question is Marmite or Vegemite? Love it or hate it?
Well, Vicky, I'm Australian, and so I grew up eating Vegemite. It's in the water supply over here, and I eat it almost every day. Marmite, in contrast, I think is English and can't stand the stuff.
Well, so I'm going to confess that I actually like both. So I don't know what that makes me, but it definitely means that I'm allowed into Australia if I try to come and visit. Okay, so on to the next question. I was interested to see when I looked up your research portfolio that you're a co-author on an interesting body of research studying education assessment, and in particular how to incorporate fairness as we try to marry objective and subjective assessments, particularly in the workplace for health professionals. So I wondered if you'd be willing to tell our listeners about that research, what you found so far and how it might be best incorporated, particularly with the push towards competency-based feedback.
Well, thanks very much for asking the question, Vicky. This work is the basis of a PhD project that is being undertaken by Naomi Valentine in Adelaide. She's a wonderful general practitioner as her first training and is now doing a PhD in medical education. And I'm very lucky to be invited to be part of her supervisory team. So just to acknowledge Naomi's work here. The work is fascinating. The ideas really arose when we started to examine the thought that increasingly in medical education and medical assessment, the role of judgment in making assessments is gaining more prominence, particularly the case in workplace-based assessment. And as you know, medicine is very much in a cognitive apprenticeship, starting with medical school and going right through to advanced training and specialty training. And so that naturally involves spending time in the work environment, learning the craft and being supervised and watched. And the assessment component there is very much judgment-based. You're being judged by your seniors and so on. So to just acknowledge in the first instance that we use judgment all the time in making assessments about our staff as they train. Interestingly, and of course, we also use judgment every day in the practice of medicine, so that the concept that we're using judgment is very familiar to all medical practitioners. So starting at that point and thinking about assessment, then we ask the question, how do we conceptualise fairness in that process? What is fair? Most people would be comfortable with the idea that an objective assessment is thought to be fair if you craft your questions correctly and say that, well, that's how we should be assessing people. But there's a lot left unsaid or not completely thought about if we just rely on this idea of objective, unbiased assessment. And so Naomi started to ask that question. And so she did initially a lot of reading, as one does in a PhD, and start to develop some ideas around a model. And she developed those ideas and since that time has started to test that model and refine that model by asking various players in the assessment space, so people who are being assessed, students and junior doctors and people who are doing the assessments. And more lately, she's been asking people in positions of seniority in medical programs about what they think of this model that she's designed to think about fairness. And it's taking shape beautifully, I must say. It is highly complex, and for those who are interested, I would refer them to the papers that Niola has written. But fundamentally, it comes down to a repeated series of concepts that give us the shape of what fairness looks like. And the elements of that model are, in order to be considered fair, an assessment process needs to be credible, it needs to be fit for purpose, it needs to be transparent, and it needs to be defensible. And all of those elements are essential elements relating to the concept of fairness. And there's a lot of elements to each of those components, but we see those components repeated in every environment that we go into when we consider medical education. So much so that one of the co-authors looked at this and thought about it and said it's almost a fractal. A fractal is a repeated shape that looks the same whichever environment you go into. It's almost a fractal, and the fractal is composed of those four elements. So, I mean, that's the fundamental issues around this idea of fairness.
Yeah, I think it's really, really important, I will say. And in the US, we tend to have quite short periods of time with our both trainees and then residents. We obviously have longer time to assess fellows. But I think that does sometimes set us up for some challenges, and having rubrics like this that actually kind of recenter you on fairness and values, I think, are really important. I wondered, actually, the other thing that your research team has been working on is looking at some of the conflicts that arise in these feedback situations, and in particular, the impact of that conflict or sensation of conflict, which could be good or could be bad, right, on the physician trainee interactions. So, sometimes people shy away from conflict, although I'm not sure it's always a bad thing. Sometimes it just means that there's multiple stakeholders with multiple different points of view. And the key to kind of resolution is finding that common ground or realignment and reframing so that people can see there's different layers and a place of synergy to be found. So I wondered if you could share with our audience some of the work you've done looking at conflict, and particularly in regard that physician-trainee relationship.
Yeah, thanks, Vicky. That, just to give some context to this, a few years ago, I realised that as part of my working life, I was quite involved in medical education and medical teaching and so on. But I had no skills. I had nobody. I'd learnt it all on the job, if you like, and it was pretty rudimentary. So what I decided to do was go and get some proper qualifications. So I went to Maastricht in the Netherlands and did a master's degree in health professions education. And it was a wonderful experience. It's run in English. It's done partly face-to-face, partly online. It takes about 2 to 3 years to complete. And they opened my eyes to the value of qualitative research. I'd always been a quantitative researcher and could barely spell qualitative when I started. But I found that the discipline or the disciplines of qualitative research answer a lot of questions that can't otherwise be answered. As part of my learning, I undertook a research project at that time and I'd thought long and hard about how to do this. And I decided that I wanted to do some research called phenomenology. And phenomenology is about trying to understand, the words are the lived experience of people in certain situations. So you look at a situation and you try and understand the individuals that are going through that and what they've lived and how they've experienced it. So one of the things that had come up over the years that had really struck a chord with me is that mostly in student-teacher interactions, things go very well and people learn and students receive feedback and it's accepted positively and it's a very positive experience. That's most of the time. Just occasionally, things go very wrong. And we, unfortunately, over the years have had a few experiences where things have gone very wrong. And I think we're not exceptional. I think this happens in all medical schools and many programs where just occasionally something very serious happens. And I thought about that for a moment, and I had one or two of my colleagues who had experienced these things, and I saw that it left them very damaged psychologically. So I said, okay, this is obviously something that happens occasionally. And in the literature, it's pretty well described what happens to the students in those types of situations. Things usually end badly for the student, but we sort of know that. But what we didn't know, and I could find really nothing, was what happens to the teachers or the supervisors or the senior staff in those situations. What do they experience and what happens to them? So that was the fundamental idea. And I really wanted to give these people a voice because I saw them walking around and I saw how hurt they'd been and what had happened to them. So I started talking to them. And so I used it's just a deep interview process, and I used some theory, conflict theory, to sort of shape the interviews and discussions and then analyse what they'd said to me. I think we did about 12 of these. And what came out was really interesting and I hope was helpful in trying to understand what's going on. One thing that you mentioned that came out very strongly was the fact that once people have gone through that and they're really been bruised and beaten, they often sort of give up and they don't re-engage with teaching, they don't re-engage with being involved in that side of their practice. I think that's a terrible thing that happens. When they are in the middle of the conflict, what often happens is that they work very hard at avoiding a bad outcome, so that they try and shy away from the conflict. And that has consequences too. And one of the big consequences of that is that they may well, if they've got a student that's not performing well and they're having a really difficult time with them, they might just end up passing them. And this is a phenomenon that's well recognised called failure to fail. And so that student goes on and moves on. So you can see that those moments of conflict, and we talked about some very spectacular ones, but even at a lower level, this concept of avoidance resulting in this idea of failure to fail has knock-on consequences for the whole community, because then we're starting to graduate people that really have not, possibly should not have been graduated. And it is a well-recognised phenomenon, and part of it is around how I think senior staff respond to conflict. So that was one of the major findings that came out of that paper. It was very interesting.
I think it's fascinating, and I think it's probably more common than people realise, and really, really important work. I'm glad you're doing it. I definitely think there are probably people who've had those experiences, and I really appreciate you sharing those insights for us today. I am going to move on now to the manuscript that we're supposed to be talking about, which is your recently published manuscript that you also presented at the American College of Rheumatology meeting in Philadelphia, which is looking at the genicular nerve block for pain management for knee osteoarthritis. I love this study because it's investigator-initiated, and often investigator-initiated studies address issues that are really important to both the patients and their clinicians at the bedside. I think of these studies as ikigai studies, or they overlap kind of what you care about, what you're good at, what the world needs, and what you can be paid to do. I guess the concept made famous by Simon Sinek in his book, What's Your Why? But the book I think we need for physician scientists is perhaps What's Your Why Not? As in, they come up from questions that you don't know the answer to at the bedside, but you ask yourself, but why not try ... And so with that lead in, I wondered, Michael, whether you could share with our listeners the story behind this manuscript. What was your why not moment? What challenges did you experience trying to get the study funded, approved, executed, and kind of what happened as you made this study happen?
Oh, Vicky, thanks. I'd never thought about it like that. And that's a really great insight into how we do a lot of our research is, it's sort of thinking about questions that come up in the clinic and what you can do about them. But how this one came about, we in the department for years, we've been working on a treatment called the suprascapular nerve block, which is at the shoulder. There's a nerve, the suprascapular nerve, that is readily accessible with anatomical landmarks that you can put a bit of local anaesthetic and steroid next to, and it results in quite significant improvement in shoulder pain for weeks to months for people. And we use this all the time in the clinic now, and we help develop that as a treatment option. We've just completed a study on the suprascapular nerve block for frozen shoulder, which is about to be published. It's one in a series of studies that we've done. So what happened with the knee? We thought, oh, well, the shoulder's probably the only place you can do this. But one of my friends and colleagues who is a radiologist, Vojvodic, who's a co-author on the paper, came up to me in the coffee shop and said, look, we're being asked to do this geniculate nerve block in private practice for the knee. And I hadn't really heard of it. So he said, well, you do all this stuff with the suprascapular nerve block. What do you think? We should maybe have a look at this. So we went to the literature, and there was almost no evidence about the efficacy of this particular intervention. There was a handful of case control studies. Very little had been published in the literature. So Frank and I sat down and said, well, why don't we design a randomised double-blind trial to really see if this thing works or not? That was the generation of the study. As you appreciate, there are so many people in the community with knee pain from osteoarthritis that it was very easy to recruit for this particular study.
Yes, I'm sure it was.
We went to the orthopaedic surgeons and said, have you got anyone with knee pain? And they said, we have hundreds of people who are all sitting around, some of them waiting for their knee replacements. And we said, well, do you mind if we try this? And they said, no, that would be fantastic. So we designed this very simple 2-armed randomised trial with this particular intervention with Frank and Finn Kai, one of the colleagues in my department who is a rheumatologist who is an ultrasound expert, running the intervention, and us randomising these people mainly from the orthopaedic knee replacement wait lists. And that's how it came about.
Great. And so had these patients had other interventions prior to coming to you?
Sure. Yeah. Well, most of them were very long way down the pathway of having long-standing knee pain. And, I think the average time that they'd had their knee pain was at least 5 years, because it's osteoarthritis, it's a chronic condition, and they were mostly older people. So they'd had all the usual interventions along the way that might be used to try and avoid having a knee replacement. So they were taking anti-inflammatories and simple analgesics. Some of them had been tried narcotics. They'd had, intra-articular injections along the way. But they were all quite advanced, and they'd all realised the limitations of these treatments. And as you'd well be aware, non-steroidals in particular in this population have their own range of problems. And so, the treatment of this for this group of people is actually quite problematic. There's not much you can give them that is safe and effective.
Your colleague, the rheumatologist who learned how to do the procedure, presumably was a relatively straightforward learning curve?
Yeah, so I think Finn saw 1 or 2, Frank demonstrated, and away she went. Very easy. So what they do is they use anatomical landmarks that they identify, and then they use the ultrasound to identify where the surrounding structures are, including arteries to avoid, and they know from their anatomy where these nerves are likely to be, and they identify them and just inject a little local anaesthetic and steroid in and around the nerves. And that very simple procedure. The anatomy is based on, anatomical studies that have been performed to tell you where the nerves are. There's obviously some variation in where the nerves are, but they're mostly fairly easy to locate, so I understand.
Yeah, perfect. And tell us a little bit about the outcome measures that you studied. I know you focused predominantly on pain outcomes, so the WOMAC score and the intermittent constant osteoarthritis pain measure. Can you tell us why you picked those, and then also comment on the intervals that you selected? So I believe it was weeks 2, 4, 8, and 12. Why did you pick those?
Yeah, okay. So good to both important questions. So pain, as you'd be aware, measuring pain is quite a complex thing. So we wanted to use more than one measure to try and get a good feel for people's pain experience. And so we selected pain measurements that were all a little bit different from each other. So we used, first up, the main outcome measures, just a simple visual analogue scale. We chose that because it's easy. People understand it. Marking something on a line is a pretty straightforward thing to do. So we chose the visual analogue scale as a sort of primary outcome measure. We chose the WOMAC because the WOMAC starts to move towards a bit of measurement of impairment as well. So we wanted to get an idea about whether managing the pain actually helped impairment a bit as well because, one of the important things about joint and joint pain is function. So we want to get a functional element into it. And the intermittent pain score, we chose that just because the pain questions were slightly different from a simple visual analog scale. And one of the things we'd learned about the suprascapular nerve block was that for some reason, the duration of the pain benefit is a lot longer than you might otherwise expect from a simple injection. And we think it has something to do with maybe the difference between neurogenic-based pain and other forms of simple pain. And it also might have something to do with central nervous system plasticity. And if you turn down a nociceptive response in a periphery, maybe that causes some subtle changes in the brain's sensitivity. So we wanted to choose another measure of pain, maybe just to try and capture some of that if we could. So it was a little bit of fishing when we selected those measures. And the last thing, we wanted to get some sort of measure of what the patients thought about it. It's all very well to have an improvement of 3 points on a visual analog scale, but do people really appreciate that it's helped them? So we want to get a patient measure. So we use this thing called the Global Perceived Effects Scale, which was the last measure that we used, which is a very simple sort of interval scale that asks people, do you think you're better? Do you feel better or not? And that was interesting too. And it just shows me the importance of asking that question because that sort of brings the research to life. It's sort of pointless to just improve people's pain if they don't think they're getting any better. And, after 12 weeks, still 1/3 of people that had the injection 12 weeks ago felt that they were better than they were at the start. So, that's pretty good. 50% at 8 weeks, 30% at 12 weeks. That's pretty good for an injection.
It is. And can you kind of drill down a little bit into those findings and kind of what the patients were telling you? So it does sound like you showed a pretty long-lasting effect. Was that longer than you expected, the 12-week?
Yeah, we didn't know because we've never done the genicular nerve block before, but it is very consistent with the suprascapular nerve block. I'm going a little bit off topic here, but we did one study with the nerve block, the suprascapular nerve block, where we did transcranial magnetic stimulation. We put this thing on people's heads and tried to measure what was going on in their brains when we did the nerve block. And we saw changes occurring in the brain waves when we were doing the nerve block. So maybe there is something going on there. So we're thinking that some of these interventions last longer than you think they might expect. So what we saw with the nerve block was that the genicular nerve block was quite similar to what we saw with the suprascapular nerve block. So I wasn't too surprised. One thing that's different, obviously, between the knee and the shoulder is that when you get up on your feet, of course, you're using that knee every minute of every day, which is not always the case with the shoulder. You can sort of protect your shoulder a bit when it's painful. You just sort of rest it. You can't really do that with the knee unless you're so limited in your mobility that you can't walk at all. So there's a bit of a difference there. So we were pleased that we found that duration of benefit. And what it means, I think, is it opens the door to saying, well, actually, this is actually a practical treatment because you can't be running off to the radiologist every 2 weeks to have your block, but you could go every 3 months.
Yeah.
So that's where that's relevant and important, the duration of benefit.
Yeah, I definitely think there's going to be a kind of niche group of people where this is actually a really beneficial thing to do, where they can't, for whatever reason, have a knee replacement, or there's some long wait list for the knee replacement. And maybe this is actually something just to sort of improve those symptoms for that time. I was actually really interested if you could cycle back to that question about function. So did you look specifically at people's mobility after the injections? Were there objective mobility measures in the outcome measures you were looking at? And is that something that you're sort of planning to look at further? And did you look at all at whether they were able to comply better with physical therapy and whether that made a difference in conjunction with the nerve block alone to kind of have a more durable improvement? Or did that identify those people who had the longer improvement from the nerve block?
Yeah, Vicky, all really good questions. So we haven't done those things yet. With, as you'd probably be aware, whenever you involve a group of patients into your research, especially if it's clinical research and you're doing it in the clinic rather than in very controlled environments, there's always this balance between getting people to be involved with things. It's all voluntary, and asking too much of them. So we thought of these things. We just said, look, for the first study at least, let's try and keep it simple, keep people involved and engaged, and not ask too much of them. And, I think that was a judgment call. You'd always love to do more. You'd always, I'd love to get them up walking, see how far they walk, get them back into the physios, get them moving. And that would give us very useful information. But we haven't done that yet. But we've got a measure of function out of the WOMAC score. There are many, many other things that we could do. So it's a good point. Just harking back to the nerve block for the frozen shoulder, that study did all of those things. And because the frozen shoulder, so much of it is about loss of function. So we're trying to improve function. And I can tell you that's the hardest study I've ever done with patients. It took 5 years to complete. And part of it was all of the demands that we had to place on patients to get the studies done. And there was people that weren't willing to do that. So it's always this balancing act when you're dealing with real human beings. And that's as far as we've got so far with the genicular block.
But trust me, I love sort of being pragmatic about it and getting at least the initial question answered. And I feel like you did definitely with this study answer that initial question of, is it beneficial? Yes, it is. Does it have a longer lasting effect than you might anticipate? Yes, it does. And how can we kind of use that and move forward and particularly use that in our patients? I think really helpful. I have a question actually about the cohort of patients that were enrolled in this study. Are you planning long-term follow-up on them at all? And I guess then a secondary question to that, have you looked at all at repeated nerve block procedures, given that the pain relief is abating at 12 weeks? Is it safe to do repeated nerve blocks in these patients? Have you looked at that at all?
Yep. Okay, so a couple of things. The long-term follow-up, no, most of them probably had their knee replacements now.
Yes.
Actually, one group I'm really interested in is, about 10% of people following knee replacement surgery have terribly successful surgery but still have pain. And I just wonder whether this intervention might be helpful for those people as well. So that's another study that could be done in this area. So the follow-up element, no. The repeat, I'm pretty confident with the question of the repeat blocks. Some people have had repeat blocks. Doesn't seem to be a problem at all. Again, harking back to our work with the suprascapular nerve block, we've had some patients who've had 30, 40 of these suprascapular nerve blocks over time. No problems at all. So it's sort of amazing. The one issue around the knee that I was a bit nervous about was if we started doing these blocks on people, would they all start falling over? Because the loss of innervation to the knee. Now, small study, 60 patients, but there doesn't seem to be any signals at all that that's the case. And I think the reason is because you're not actually causing a sort of a Charcot joint. You're not knocking out all of the pain. You're reducing the pain. You're not knocking out all of it. And all of those other receptors that are there inside the joint for proprioception and so on, they're all still there. They're not knocked out. So we don't seem to be causing people to fall over when we do these. That would be the sort of fear factor for me in terms of safety. I'd be confident we could repeat them if we needed to.
That's great. And do you have any plans to look at imaging? So I'm kind of interested, obviously you selected for this study people who were waiting for their knee replacement, so people who had pretty advanced osteoarthritis. I'm wondering if you have any plans to recruit patients earlier in the course of osteoarthritis and look at imaging changes, and particularly, I guess, does it slow progression because they're then able to mobilize more, or does it worsen progression because, there's some silent level of damage that's happening?
Mm-hmm. A really good question. I hadn't thought of it. Hadn't considered that we would be using it as a long-term treatment option for people with knee pain. That's not how I'd envisaged its role. But yeah, I mean, that's a pretty good question, isn't it? If you continue to block somebody's knee, do you accelerate their osteoarthritis? That would be an awful outcome to occur. That would have to be quite a long-term follow-up type study, and I'd have to probably give that to my younger colleagues if we were going to do that. So no, we hadn't thought of it. A good idea. I know the sort of concept of studies that you mean, because there's been a number of those looking at intra articular injection and seeing whether that accelerates the osteoarthritis.
And so particularly, I guess, with these monoclonals that were inhibiting nerve growth factors that initially really looked super promising in terms of pain outcomes and then have run into challenges because of more rapid progression of joint damage, kind of circling back to that question of if the patient can't feel it, is it hurting the joint, I guess?
Good question. And as I said, I've never sort of envisaged this treatment as a sort of a long-term option. So probably less relevant as a question, but nonetheless, theoretically, it's an important question. Yeah.
So really your kind of group is considering this as more a palliative option or a bridging option to get people to the point where they can get their knee replacement?
Certainly at this stage, or of course the other group is people who aren't fit to have their knee replaced. We've got a lot of those people, who are maybe, more elderly and just knee replacement's not an option for them. And this could become a very good option for them. So, and as for accelerating their osteoarthritis, that probably wouldn't matter at all at that point. So, that's my view of where it would fit.
Yeah, no, and I completely agree. I think it has a definite group of patients that would really be finding benefit from it. I truly appreciate you joining us on the show today and sharing your research, telling us about this study and your other work. I want to congratulate your team at Flinders University actually for setting it up. I love investigator-initiated work. I think it finds like that sweet spot of what matters to the patient and what matters to the clinician. And you definitely seem to have achieved that with this study. So congratulations.
Vicky, thanks very much, and thanks for inviting me. It's a real pleasure and quite an honour to get to be able to talk about what we do.
I want to close by offering some words of encouragement to all those physician scientists toiling away on Ikigai projects. Remember, you don't have to wait for others to believe in you if you believe in yourself. And when you're stuck trying to find your purpose, remember that in the same sentence you wonder why, you can also ask, why not? Thank you all for listening to this show. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media and rate and subscribe to our podcast at acronair.org or wherever you get your podcasts.